Welcome everybody to our webinar on the Compassionate Connectors program. Thank you for joining us. If you're in Canada, we know it's pretty early this morning. I know as well we have people from all over the world, so thank you for joining us. If you can put where you're from in the chat, we'd love to see that. And yeah, let's get started. So you're here today to learn about the Community Connectors program and the body of research that has been produced from that out of Australia. And it's seen as a distinct form of end-of-life volunteering. And our presenters today will be Prof. Anau and Professor Bruce Rumbold as well. And I'm Bonnie Tompkins, so thank you for joining us. Next slide, please. Would like to take a minute to do my territorial honoring, and I think probably our presenters will be as well. So I'm Bonnie, and I wanted to take the moment to acknowledge the land that I am presenting from today, which is in the city of St. Catharines, and that is the traditional unceded territory of the Mississaugas of the First Credit Nation and the Mississaugas and Haudenosaunee, the League of Five Nations people. I would also like to acknowledge the land I was born on in New Brunswick, which is the unceded territory of the Wabanaki people. Would either of the presenters like to do a land acknowledgement?
Yes, well, I'm Bruce Rumbold, and I'm coming from Wurundjeri country, which is around Melbourne in the the eastern edge of the bottom eastern edge of Australia. Traditional lands that have never been ceded. And Samar, you're from your new country, are you not?
Yes, hi, I'm Samar Awon. I'd like to acknowledge the Nura people of this area and pay respect to their elders past, present, and future.
Indeed.
Next slide, please. So we'd also like to take a minute just to talk a little about the Palliative Care Echo Project, who is bringing us this webinar today. So the Palliative Care Echo Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare professionals and the community across Canada who are caring for our patients with life-limiting illness. So if you'd like to learn more, you can see the link there on the slide. And we'd also like to acknowledge the financial contribution of Health Canada for supporting this ECHO program. Next slide, please. So just some quick introduction. So I'm Bonnie Tompkins. I'm the Compassionate Communities National Lead at Palliative Canada, and I'm also a council member with the Public Health Palliative Care International Council. So that's my role, and I will be facilitating today. And as mentioned, we have 2 presenters with us this morning to present on this body of research in the program. So I'll just read a quick little bio about them. So Professor Anau is an international leader in the promotion and advocacy of public health approaches to palliative care and led this approach for those living with grief and bereavement. She is known as an innovator and a champion of practice and policy translation of public health science for palliative care. Her work on social models and bereavement support has provided empirical evidence to strengthen the compassionate communities approach. Samar advocates for a person-centered health and social care. Her research programs on supporting family carers at end of life and the public health approach to bereavement care have informed policy and practice at the national and international levels. She is also a Perron Institute Research Chair in Palliative Care at the University of Western Australia. She co-founded and chairs the Southwest Compassionate Communities Network in Western Australia and has led the Compassionate Connectors program, which offers practical and social support needed by families with life-limiting illness. This program has been embedded into standard practice by the health service, with volunteers working alongside palliative care and chronic disease teams. So thank you and welcome.
Thank you.
Next on to Professor Rumbold, recently retired from his position of Director of Public Health Palliative Care Unit at the La Trobe University in Melbourne, Australia, and is now an adjunct professor in the School of Psychology and Public Health at La Trobe, and a senior research fellow at the Perrone Institute in Perth. Bruce's ongoing multi-interdisciplinary interests are supported by postgraduate qualifications in social state physics, practical theology, and health social science. Interesting. After 10 years in parish ministry with a focus on community development, he was a professor of pastoral studies at the University of Divinity in Melbourne. He moved to La Trobe University part-time in '99 to become a foundation member of Alan Callagher's Health Promoting Palliative Care Unit, transitioning to a full-time appointment in 2002. Social determinants of end-of-life experience, forming and sustaining compassionate communities, and spiritual care are of particular focus for his work. So thank you very much, you two, for joining us. Next slide, please. So just sort of conflicts of interest, just to share that information with you guys. So Pallium is a charitable organization. We are partially funded by Health Canada, and we generate funds to support our operations and research and development through our course registrations, for instance, with our healthcare courses. And I, Bonnie Tompkins, myself, I work for Pallium and I also sit on the council, but other than that, I have no conflict of interest, and it appears our two presenters have no conflict of interest as well. Next slide, please. So just a couple little reminders about the session today. So we will be here for an hour and a half. So we have left a good amount of time for you guys to really ask some questions. So we look forward to that at the end. So basically what we'd love to see is if you have comments or if you have any technical issues, because we do have two great ECHO staff, Diana and Aaliyah, on here with us. So if you have questions, you're having trouble, please put those in the chat and they will help you guys out. And then we're going to try and drive all the questions to the Q&A function. And that's what we will use at the end to answer your questions. And just so you guys know, the session is recorded and you will get a copy of the recording within about a week or so. Next slide, please. And also we'd like to acknowledge that this webinar is being co-presented with Public Health Palliative Care International. And so, we'd like to acknowledge them as well. Next slide, please. So just a little bit about Public Health Palliative Care International, just in case there are some new faces to the organization on here. So some of our aims are specifically to promote health promotion, right? The values, the concepts and methods of health promotion, but within the palliative care service everywhere. So that's one of our aims. Another one is to support members in their educational and practical needs to meet the goals of health promoting palliative care. So on the website, you will find a tab full of resources that have been developed and available around the world. Another aim is to provide regular forums for connection in the aspects of a conference every 2 years. You'll see our next coming conference at the end of the presentation today, but then also webinars as well as an opportunity for us to connect and share research and ask questions. And to encourage and foster research and evaluation of health promotion, health promoting palliative care, to encourage palliative care, to foster professional linkages and knowledge exchange between colleagues in public health, community health and development, health policy, health education, health promotion, end-of-life care. And really to provide a global forum for communication with its members who are involved in different aspects of that work. And to support network and mentor students as well in their efforts for future development and evaluation of this approach. And lastly, to collaborate effectively with all organizations that represent people affected by dying, death, loss, and care. So next slide, please. All right, I'm going to hand it over to our presenters. So thank you very much.
Good. Well, thank you indeed, Bonnie, and thank you all of you for your presence at varying hours of the day or night. It's good to have this opportunity to share some of this program with you. As you can see, Compassionate Connectors program is essentially the locates it within a compassionate communities approach, and my role is to top and tail this presentation. In a sense, I'm a bit of a historical exhibit myself, and I remind you of some of the concepts that underlie it. First of all, that compassionate communities is a practice, an idea, an aspiration. Compassion is something which recognizes our fundamental connectedness as human beings. And that in itself challenges other ideologies which operate on separation and division. So a compassionate communities approach is inclusive. It's committed to systematic change, to building a society of inclusion in which gives particular attention to equity, to fairness, to an opportunity for all citizens to have a voice in the affairs that concern them. And as such, compassionate communities is a key element of a public health palliative care approach. And public health palliative care approach, as Bonnie's already reminded us, is a health promoting approach which to end-of-life care, which regards the community or views the community as an equal partner in the complex task of providing quality healthcare at the end of life. And that's a particular vision, I guess, that we return to toward the end of this presentation. But in that sense, end-of-life care is everybody's business. For some of us, people in my generation, it's actually a fairly immediate part of everyday life. But for others, it is something which impinges it from time to time. But each of us has a role in some sense within the business of end-of-life care. The compassionate communities movement is something which provides an appropriate place for people who are sick and dying, grieving, caring, to belong and to contribute. And in fact, there's a whole range of strategies and programs that attempt to implement the idea of compassionate communities. And this program that we're to talk about in this session is one of them. The starting point is, in fact, a fairly simple explanation idea. Sorry, I think I have to say next at this point.
Oh, okay.
Yes. I don't seem to have a control here. Okay, so undergirding the idea of the program is this, that within Australia at least, for people who are living in community with a life-limiting illness, less than 5% of their care, even toward the end of life, is in contact with formal care. That is, people who are registered healthcare professionals. So the other 95% of the day is where care and support is provided informally from a whole range of people within the family, the neighbors, family, friends, the pets, complementary therapists, you name it. But it's an area in which we do not know a huge amount. So it's not actually a matter of rocket science to recognize that if we are going to improve end-of-life care, we should pay attention to that 95%, as well as improving the skills and the performance of the 5% of formal care to which people have access. And that's a point at which somehow takes us into one of the more grounded aspects of this stuff. Okay.
Thank you, Bruce, and thanks for the organizers, Palliative, ECHO, and PHPCI, and welcome everybody. Good morning and good evening at the same time from across the globe. So, for a long time in compassionate communities, we really needed more evidence that the community is really doing a good job in terms of supporting each other. I mean, we always knew it is happening, But the sector has always called for more evaluations, more evidence, and hence this is what we were presenting here. So at some stage, we wanted to know from people who were supporting them at bereavement, post the death of their loved one. And we had a national survey, about 1,000 people replied. And it's, as you can see, it's quite clear that families and friends, about 90%, and then funeral providers really were also one of the most predominant sources of support. Let me see what's going to happen when I do that. Yeah, but when you look at the red section, the lower one, where the professionals, mental health professionals or bereavement specialists, very few people, got into that space. The middle section, about 30%, would be calling on help from the community, from healthcare practitioners, not necessarily in the mental health field or in the bereavement field, like GP, pharmacist, community groups. And then the majority is in top three section, where basically it's the informal care where they've relied on. So that was a really important piece of information to have, and sort of an empirical evidence that compassionate communities are really doing well in terms of supporting each other. So you may have seen the pyramid, the public health model of bereavement support, where from the literature and also from the survey that we have done, it showed that 60% would have low risk. And so the majority of people can deal with their grief with support of family and friends. The middle part, the moderate risk, that would be in need of some additional support, peer support, volunteer-led group, and I suppose the Compassionate Connectors program we're going to talk about sits in that space. And the high risk, again, those with complicated grief where they need a referral to mental health professionals. So we also asked in the survey, okay, you rely a lot on family and friends. How helpful are they compared to the other sources of support? So as you can see here, bars is where people said it was, very, very and quite helpful. And again, family, friends, and funeral providers came quite high in terms of helpfulness. And then you see all these yellow, not helpful, or, not so much, sort of creeping more into the other groups of support. So fantastic news, not only we rely on family, friends, but also they're doing a good job according to what the bereaved people have said. So where did we go with this public health model for bereavement support? It's been translated at several sort of levels. The first one, obviously, in Australia, we had Palliative Care Australia having a standard 6 in bereavement support, in grief support, and also during the COVID-19 era, they produced the second document whereby I think bereavement was more pronounced if people really needed more help with the extra mortality due to COVID-19. Then the Irish Hospice Foundation have really built their policies around that pyramid as well, and the structure of it. The other group in the UK, the National Bereavement Alliance for Kids, again, I've received quite a lot of emails from them to say that how helpful this model was for their resource allocation and how they were able to organize their services around that. The other group are the EAPC, European Association for Palliative Care. They were at that stage developing bereavement guidelines. Again, they drew on this model, public health model. King's College have also emailed at a few stages saying, how important this work was. And I think we had one of the best sort of articles in 2018. But then again, I think what's really was important for us is to, from the health practitioners, to come to us and say how important this work for their practice was and how it's also was helpful for them. So move on from there. We're just going to sort of talk a little bit about what is the situation in Australia, and I'm sure it probably be the same in other developed countries. In the next 25 years, the number of Australians dying will double. I've had research that showed that many Australians are dying in a way, in a place that doesn't reflect their values or their choices. And their end-of-life journey is punctuated with avoidable or unwanted admissions to hospital, with the confusion loss of dignity and loss of control that comes with it. So we really need to do something about that. And this statement by Professor Alan Kelleher is really stuck with me from the moment I read it. It's just so important. Death is a social event with a medical component. It is not a medical event with a social component. And so true now in this era where death has become too professionalized, too institutionalized. So how are we doing in Australia? Dying is increasingly becoming institutionalized with 25% increase in hospital palliative care admissions. Spending on key health services is 14 times higher for Australians in the last year of life, and you can compare the dollar amount between the two. Hospital is 3 times more expensive than community palliative care. Again, there's a lot of research on about where we want to die. 70 to 80% want to die at home, but only 14 to 20% are able to do so, and mainly they are in hospitals happening. 75% of Australians haven't had end-of-life discussions, and less than 10% of us die with an advanced care directive. And this is a place where our WA Health, WA stands for Western Australia, WA Health and also our palliative care Western Australia, they've been doing a lot of work around advanced health directives and advanced care planning. Now, the most, I suppose, killer that we're going to look at is social isolation all over the world. And you may have seen recently the US, they had an interview with a Sergeant General talking about how the situation is bad. So here in Australia, nearly 50% of over 60 years old are at risk of social isolation, and 1/3 will experience some degree of loneliness later in life. And I think this is something that all of us, basically, we need to look at how can we help with this. Now, social connectedness and its impact cannot be overlooked. It is really a health determinant, whether for mental health or physical. And there is Waldinger's research that really showed that people who are more socially connected are happier, physically healthier, and live longer, while people who are socially isolated is the total opposite. They're less happy, their health declines earlier in midlife, brain function declines sooner, and they live shorter lives. So again, this great work from Holt Lunstead, whereby shows the impact of social relationships on reduction of mortality. And as you can see with the 2 underlined items, the impact is much stronger than cessation of smoking, blood pressure, nutrition, which is, quite amazing. So what are the benefits of a compassionate community? People with a life-limiting chronic illness and their carers are supported. There's increased equity of services. Community members have a sense of purpose in supporting their community members. People learn how to care for one another at the end of life and can share this with others. And of course, there are financial savings. And Dr. Julian Abel in the UK and his leading research in Frome showed like a significant reduction in hospital admission for those people who were able to have that compassionate community approach to care with primary healthcare. So looking at all this really good evidence that we have now, we started in the southwest of Western Australia, our Southwest Compassionate Communities Network. And our motto is for every person, every family, and every community knows what to do when someone is caring, dying, or grieving. So you can see where the southwest is, Bunbury, on the left-hand side of the Australian map. This is the regional centre. And the southwest is that area all around it. So at that stage, groundswell called for expression of interest for people who want to start compassionate communities. So we put our hand up, and the other ones are on the other side of the country, where Sydney, Melbourne, and Queensland are, just to give a bit of perspective for our international attendees. So these are the first group of the compassionate community connectors that we started with. Now you can see this photo was taken during COVID. We all had to stand so far away from each other. Not a nice souvenir, but it goes in history basically now. And this is a program that we did in partnership with our health service. It's called the West Australian Country Health Service for the area of the Southwest. And the objectives were to develop and evaluate a model of community volunteers to support people living with advanced life-limiting illness or palliative care needs, develop and evaluate a training program, and assess the feasibility and acceptability and preliminary effectiveness of this community model of care. So in the training program, we had a manual, and this is what we covered: understanding the public health palliative care approach and what compassionate communities are about, understanding advanced illness and the role and capacity of our teams in terms of chronic disease and palliative care, death literacy, advanced care planning, grief literacy, communication skills, confidentiality, self-care, boundaries and endings. At the time when we were doing the research trials, we talked about why we're doing the research and the importance of the evaluation tools that we were collecting. And of course, the health service itself had their own rules and regulations and security checks and all that stuff that they all needed to go through and understand the protocols. So I think that's probably similar to a lot of the training programs in this particular field. Just to show that although we started with a group of connectors who had a really reasonable and moderate level of death literacy, they've all had lived experiences. They've looked after people who were dying. Still, the program or the training had showed that there was an increase in their confidence in terms of having to deal with a lot of the issues that we covered in the training program, which was fantastic. We started by a 2-day program, but then we found out it's better to do a 1-day and then expand on, say, advanced care planning or grief support in future sessions. So it's more like an information session in a way. And as we did more and more, as we had more and more of the connectors joining and we're developing the program, there were real scenarios that we could put forward and discuss in those training programs. So they were quite interactive. The program dealt with those 3 target groups: the patients and their families, the connectors, and the caring helpers. I'll explain the difference between the 2. So the connectors undertake the network mapping. They go into a family and they say, who is your network and how will they respond? And, as you know, unfortunately, we've reached a stage where people are not asking for help for all sorts of reasons. They don't want to look like they don't know what they're doing. They don't want to burden their families. And that's really detrimental because if families in need do not ask for help, they are really de-skilling their communities from getting the skills to be able to help them and other people as well. So that's a crucial thing, because we have a lot of people in the community who want to help, but they don't know how, or they're too scared they may get it right, or they may get it wrong, and all the privacy, confidentiality issues that, we are all bogged with. And then you have on the other end the families who need help, and when you ask them, they say, oh no, I'm fine, thank you, I don't need help. So it's just, how do you get those 2 groups together, basically? So within those circles of care that, again, Dr. Julian Abel has talked about in one of his articles, you've got the inner informal network around the family, the outer, the community, and then the health professionals come. So the role of the connector is distinctly to enhance the networks within those circles of care. They look for assistance in the community for those people, for any additional social or practical support they may require from their own community, and would tap into formal and informal sources. Now, these informal sources would be the caring helpers, who, as our families call them, the doers. They're the ones who actually go and do these little things, as in the literature they're called, but they're not really little for those families. They're so important for them because it restores their dignity and shows that we really love them. We're normalizing their life, even though they are, dying. And, to have somebody walk their dog, doing their shopping, collecting prescription, going to the library, mowing the lawn, making a snack, tidying up, and that important cuppa, to be there for that person and have a coffee or tea with them and have that chat could not be underestimated. That is just so being, I mean, in the scheme of things, this is what people have looked for more than anything else. So in terms of how it worked, the health professionals in the health service would refer families that are appropriate for the program to the coordinator of connectors. So the coordinator of connectors is the only one who's paid. And at that time, she was employed 2 days a week. And the coordinator of connector, the suitability of the families, and those who would have a high level of unmet need and low level of network support would be the first one that would be included in the program. So who is helping? And these are the domains where people have asked for help: personal care, medical, home, transport, social, food, pet animal, and preparation for end of life. The 20 connectors who did the training, that was in July 2020, 13 of them were able to participate, 12 female and 1 male. Median age of the connectors was 62.5 years, although we had young ones like 28 years and not so young ones, 74. Follow-up of families was for a median of 18 weeks. And again, it ranged from 3 weeks to a whole year, depending on the need of the family. The average number of families per connectors were 3, but some could only manage 1, and some did manage 9 families. So it's very much what they can fit in their normal life. We've asked the connector to keep track of the contacts they're doing and the number of hours. Some did, some didn't. They never like to collect information, but that's fine, we understand that. So this amount is just really quite an underestimate. So community volunteers, and I like this quote from Salno and Kumar, are trained to diagnose suffering, not diseases. That's why when Bruce said it's inclusive, it's about everybody, basically. It's just the amount of suffering, that matters for the connectors and the caring helpers. In terms of patients, we started recruiting from palliative care, but because patients are referred too late for palliative care anyway, by the time palliative care would refer to the connector program, families were just absolutely towards the end, and we probably lost half of them due to death. So we went upstream a bit more and started including people with chronic disease, but advanced chronic disease. So we ended up with 43 families who were able to participate and be part of the testing the outcomes measures before and after the intervention. Now, 47% home alone, and it did look like this is what the services are struggling with. They're just not able to actually expand their services to people who have no one really living with them. I think those people, it's not like they didn't have anyone, but they were totally disconnected from their families and they couldn't ask them for help. The median age of the patients was 74 years, again, ranging from 34 to 90, and 44% were male. 47% had cancer, 33% cardiac respiratory, and 14% neurological. Now, just recently, our Australian Bureau of Statistics showed us that Bunbury, the regional center for the Southwest, had the highest percentage of single-person households. So in all Australia, which was really, it took us by surprise, but it explains probably why we had so many people who are home alone anyway. So people need help. So as you can look at the percentages around that wheel, 76.9% was social needs, much more than any of the other domains that, we were, or the connectors and the caring helpers were able to help them. And invariably it was, please stay with me and just, have a cup of tea with me. I just want to chat about my life, my, end of life, my family's dynamics, whatever it is. And yeah, because I had no one else. So some of the areas where the connectors have helped or sourced help for them, for people if they want to, prepare their wills, advanced health directives, they brought in professionals to people's home who couldn't go out to do that. We've got some, my aged care applications, whereby, again, people apply for them to get more help, disability applications, equipment access, meal delivery, organizing meal train, house cleaning, joining community groups, all-time dancing, crafts, walking groups, men's shed, surrogate grannies for family with kids, transport to medical appointments or social occasions, gardening, fire food delivery, social visits. But most importantly is that those feelings of empowerment and ownership, you can do this, for the families who basically have, like, because of everything they are going through, they've sort of dropped the bundle really completely. In terms of the type of caring helpers who the connectors were able to source from the community and beyond, again, family and neighbors didn't figure out a lot because of the high percentage of home alone that we had in this sample. But as you can see, 18% were community service groups and 25% were individual community members. Now, an example, say, of an individual community member, we had a lady who moved to Bunbury from a really smaller town. She had a lot of comorbidities, anxiety, and she just couldn't get herself to drive her car to go and see where the library is, where the supermarket is, so that she can look after herself. So we reached out to a Rotary Club, a service club, and said, look, could you have somebody there who would be happy to sit with this lady in her car as a passenger and just show her around to give her the confidence, to be able to, engage in the community life. And this is what happened. This lady sat with the patient and took her around to show her around, and then three visits, three, I suppose, car rides, and that was it. The lady was saying, after this, my life has really increased from a golf ball size to a basketball size, because the world had opened for her in this new city where she decided to move. So all in all, we had 26% of the help come from naturally occurring networks, and 59% were from externally facilitated networks. How did we measure social connectedness? We used the MOS, which is a Modified Medical Outcome Studies Social Support Survey, and it had two subscales, one on practical and tangible support and one on social emotional support. The practical and tangible support ask questions: do you have someone to help you if you are confined to bed? Someone to take you to the doctor if you need it? Someone to prepare your meals if you are unable to do it yourself? Someone to help you with daily chores if you were sick? The social emotional, someone to have a good time with, someone to turn to for suggestions about how to deal with a personal problem, someone who understands your problem, someone to love and make you feel wanted. So the pre-intervention is in green, the post-intervention is in blue. As you have seen, as you can see, it's a significant increase in social connectedness for those families, the way they've felt before and after the intervention. Then we put together like an assessment of the practical and social needs and support networks, and we had a scale for that, depending on their dependency and availability of support. And we looked at that pre and post intervention. While their dependency stayed the same, of course, they're very sick people and they need help all the time, the availability of their supportive networks had increased by twofolds post intervention, and that was quite a significant increase. Yeah. Then we asked the patients themselves and also the connectors themselves to rate on a scale from 1 to 4 what would be the highest impact that this program has had for them as the families, and what did the connectors think their impact was. So the orange one is what the patients have said and their families. The highest impact was reduced social isolation, followed by coping with daily activity. Now you notice the connectors have rated themselves lower, and that's come across in the literature a lot, where volunteers are so humble, they don't think that the effort they're doing is bringing in all that reward for the families. And certainly that was a good thing to show them, because they were very surprised that that little effort that they thought were doing has so much impact on the families. So this is just to show how before the intervention on the left, the networks of this particular family in terms of 2 neighbors, 2 family members, 3 friends, and so on. And then when the connector and the caring helper started being part of that network, you can see more of the interactions happening between not only the family and all these people, but also between the people themselves as well, trying to see how they can provide help for that family. We also did interviews, 74 interviews in total, 28 interviews with the families, 27 interviews with 11 connectors, but we covered the topics of 37 patients with them, and 19 interviews with 8 health professionals covering 20 of the patients that they referred. So the patient and carer feedback, some of the quotes that were provided: always keeps her promises. A lot of paid carers really don't care, just filling in the hours. She goes above and beyond and seems to care. She knew when we were a bit overwhelmed, knew when to get involved and when to step back. Necessary for people who don't have strong existing networks. For people who are isolated, it will help open up their world. I can ask her anything, no matter what I talk to her about, she always has a sensible answer. So in short, pretty amazing. The key themes, we've had all that published, and I'll show you the articles in a little while. But the key themes that when we did the thematic analysis from the healthcare providers, they reduced social isolation. The program reduced social isolation, life-changing for some patients. That increased more layers of support for them. It certainly filled the gap in service provision. They call it another string to the bow, building the capacity of the service that way. The home card making, this is one of the caring helpers who I was making card with a lady who has COPD, and she couldn't really leave home. Another way that this church group helped after on Sunday, they helped this elderly guy in his garden. The garden meant a lot to him, but because he had so many disabilities, he wasn't able to look after his garden. And he spoke about a blackness that would flood over him and loom for days like a heavy rain cloud. That blackness has gone now. So I think there was a bit of a mid-order of the slides. So the healthcare team I've sort of mentioned before in terms of the their thematic analysis from the article. But these are some more sort of quotes that they've said, really positive, especially for clients who are early in their journey and for those who are isolated and don't have good family support. I'll be encouraging more people to make use of informal networks and support, which is great. We wanted, healthcare professionals to start working with us about looking at that informal networks instead of trying to find another paid service where it's probably not really the right place for these families to be connecting with. She's very socially isolated, and our professional service is not enough to meet her social needs. So I'm very happy for her that she has a consistent person to talk to. It added another string to our bow, especially in small rural areas where there's a lack of formal services. Easy to implement. Yeah, so we've managed to do that one before. Now, what did the connectors say? Great to be given someone specifically to help fill their needs and tick their boxes. So rewarding to watch their quality of life improve. Being able to connect to those in need has brought very obvious benefits to both the volunteers and the receivers. The more you give, the better the reward. The reward is greater than the effort. It's a fabulous program. So the key themes that came from the articles on the connectors experience, there were mutual benefits from this connection and reciprocity. It was okay to ask for help and receive help. This is the sort of theme that they try to work with the families. Sense of community as being part of a village, it brought in that village feeling again, making a difference in social connectedness. Frustration when not achieving everything you want to. Obviously, it wasn't quite smooth for all of them because some families probably resisted, the help that offered to them. And they reflected quite a bit on the difference with traditional volunteering, because some of them came from hospital volunteering or hospice volunteering. And it was very interesting to discuss, when we heard their feedback on this, to discuss a bit more on this, and Bruce will be sort of expanding on this a bit later on. And just recently we finished the effectiveness analysis, and we found out that there was a significant decline in the frequency of hospitalization per month for the group that were followed up by the connectors compared to a historical control. that was matched by age, gender, a clinical diagnosis, and home alone status. The other significant outcome was a decline in the number of hospital days per month, and there was an increased use of outpatient services. When we discussed the results with the connectors and also the health service itself, the significant decline in the hospitalization, the information that was given to us, or the explanation, is that there will be a lot of, there used to be, or still probably, a lot of admissions to hospital on the weekend, when these families or patients would freak out because they're not feeling well, but really they're by themselves, they don't know what to do, so they admit themselves to hospital. While when they had a supportive network around them and the connectors and caring helpers, they would call on them anytime during the day or night, weekend, which they couldn't really deal with in terms of if a service provider, because it was just during work hours that they were available. And then once they were admitted to the hospital, they really didn't want to stay more than it's needed, like they used to do, because they've got people outside now in their community who they love them and they want to spend time with them, instead of having to drag their stay for more than it's needed if they didn't need to stay there. Increased use of outpatient services and other community-based services. That was interesting too, because the connectors were actually helping those families make the appointments if they need to go to one, and also making sure somebody is able to transport them to those services, and hence that's increased the use of that. So the cost effectiveness analysis, also the net savings of the connector program, was on average about just over $500,000 of Australian dollars over a 6 months period, which is quite significant. And we haven't added all the other benefits as well that is there. So just based on those, 3 outcomes. So I'll just play now a short video to show you how the connectors were dealing with those families, and we'll carry on a bit later on that. So click the button, Anya.
I think the community needs to be there to support. Death's not a secret, but sadly we often treat it as a secret.
I'm a New Zealand born Māori, and I met my husband Malcolm at Teachers Training College in New Zealand in 1970, and we married in 1972. I guess I can describe Malcolm as he didn't have any enemies, and there wasn't anyone that didn't like him. Because he was strong, he was frightened about dying.
I met Gus in 1980 at the Blacktown Workers Club, mid-year, and 5 days later we moved in together. So we've been together nearly 41 years. We married in 88, and by that time we had 6 children. So we're a blended family. Gus had 2 children, I had 2 children, we had 2 children. Gus was very, very fit. He was, he'd gone back to uni as a mature age, around about 60 years old, I think he went back. Loved books, writers, authors, always had. He always thought he had a book in him. They say everyone has, and he did have. And then he became ill, and we never thought it would last.
For the first few days, the doctors were saying he's got a very big growth on his lung, and he would not be surviving probably days. It wasn't going to be long. And so, because he didn't want to die, he wasn't ready, we asked really that we go somewhere that we can, help to. The doctors were worried that we were trying to prolong Malk's life because we didn't want him to leave, but that wasn't the case at all. We didn't want him to leave until he was ready to leave, until he was ready to die. So in there I looked at the compassionate program and asked to join and be part of it.
To have Gus suddenly, very, very suddenly unwell, it just threw us in a tailspin. I think everyone knows they could get sick at some point, but you never think it's going to be you. And we never thought it'd be permanent.
We still have kids sitting in desks.
I came into contact with this connection, this program. There was something left after a meeting in hospital, and I looked at it and wondered about it, and had put our names down, talked to it about it with Malc.
I had the privilege of coming in and meeting with Mary and Malcolm. I could see they both had needs. Both were so loving towards each other and were so worried about the other person they weren't discussing their individual needs. My role was to come in and I guess get that conversation going. Both incredibly capable people, and I saw myself as being an advocate, just to slow them down and say, what do you need? Yes, you're capable of doing that, you can do that, you're intelligent people and you're in control of this situation.
It was wonderful meeting Jenny, and we got on straight away. And she's the type of person that you can talk safely with, if that makes sense. That you can sit down and you can have a conversation and talk about things that you can't talk about to other people, about how this has impacted on your life, and be honest. You don't always get the opportunity with family or friends to be honest.
I do a lot of listening with Jenny, and with Gus I was able to get a retired principal to go in and spend time with him. Gus is a very academic man and he likes an intellectual conversation, so it's sort of finding people that kind of meet that need. Yeah.
On end-of-life care, upskilling the community is a really key point that we are working towards in the Compassionate Communities Network. There's nothing worse when, somebody dies and then the family is lost. What do they want? We've never had that conversation. And I think this is where the community needs to focus on, and I think we will get a much better advanced care planning than, say, a clinician doing this in a hospital or a clinic, because we're talking about a life.
No one wants to feel helpless, and it took me a little while to realise that this wasn't so much about helping, it was about supporting and being beside people during times when they otherwise couldn't cope on their own, and that was me. I was just overwhelmed.
I would have completely, I believe, fallen over if I hadn't had the Compassionate program and being involved with Jenny in the Compassionate program.
Nobody wants to die, but if people are allowed to speak about their fears around death, I think it makes that process more bearable for them and those that love them.
Great. I hope you enjoyed seeing how our beautiful connectors, are operating in this sphere. So over to Bruce now to talk more about this form of volunteering.
Well, we've talked about it as a distinct form of volunteering, but particularly so in the Australian context, because that's what we can speak to. Most of our volunteer programs with Australian Health Services are essentially programs that extend the work of the health service. That is, volunteers are trained, they are given particular tasks, they report back. Any initiatives that are taken have to go back through the health service. In this particular arrangement, the connector arrangement, the connectors are trained, but they have agency, autonomy in the way they can operate. They operate as members of the community, representatives of the community, citizens, I guess. And in that sense, the freedom that they have to respond and take initiative somehow is reflected in the people they work with also rediscovering their autonomy and their agency in the situation. And in that way too, because it's a more open form of relationship or a community-based relationship, social capital gets built within these genuine social encounters, which persist through and beyond the experience of companioning through dying. And there's a couple of those comments there. A number of people who were connectors had previously been volunteers, and they experienced this form of compassionate connection as building upon and enhancing, but going further, being more meaningful for them in their contributions. Now, we've published about this, and I'm rather aware of time that we need to keep going for some discussion. So you've had some of these papers given to you. Here they are in outline, the title page of them. So, and we also need to head back to summer, talk about the impact of the program and the way in which it's been translated and becoming sustainable.
Yeah, thanks, Bruce. So where do we go from here? So as I mentioned, it was a successful program also from the health service perspective. And they've now integrated the program as a standard piece with the coordinator of connectors role embedded in her role as chronic disease management. Then the next one is about we're talking about a few communities throughout Western Australia, how we get this program going there. The next on the agenda would be how do we engage with primary care, the same way, hopefully, that was done in FOOM, or maybe, we have our own ways of doing it here. And we reached out to local government, and we talked about having a bigger vision for the community through developing a compassionate Bunbury Charter, focusing now on the regional centres. So we have developed this through extensive community consultations over the last sort of 9 months. And the idea of getting this Compassionate Bunbury Charter is to guide and encourage the community, including individual consumers, service providers, businesses, community groups, clubs, schools, to work together to create a more compassionate city that's resilient, responsive, and understands the need for community support to get through difficult times. From the community consultations, we have now this sort of diagram that summarizes where all the actions sort of need to happen and where people need to reach out for some toolkits. I mean, we did develop a toolkit as well. So it's about supporting good communication, respecting people's wishes, fostering belonging and connectedness, providing opportunities to remember, nurturing creativity. The arts sector is very important here. Leaders who are championing care and compassion, creating caring organizations, acknowledging compassionate acts. Hopefully the mayor would have an award for the most compassionate workplace or school. We're working on this, and building capacity to give and receive. I may have said the other one. So how do we make this as operationalized and sustainable? And this is the idea, is now we have this bigger vision for the community that brings values to life and death. It'll inform policies and structures and resources for all sorts of workplaces and schools. And then it's already been embedded in one of the strategic community plans of the city, but future plans as well would have that. And the idea is to have all of services, facilities, and programs that can support good quality of life for people who are experiencing hardship, illness, and death. Again, what we have found out when we did a review of palliative care services in our state, Western Australia, from a consumer's perspective, what we call the pressure points, and Julian Abel called the blind points of palliative care. And hence why palliative care, certainly in Australia, it's not accessible to everyone and everywhere. And that's the aim that we are working towards, basically, with compassionate communities, particularly to cover those blind spots and pressure points whereby non-cancer conditions have more equity of access. Family carers are better more support for grief and bereavement, which is at the moment quite ad hoc. Health and death literacy of consumers. So, I mean, this is what consumers have asked for. And then again, as I said, the West Australian Health Service and the Palliative Care Association have been working in that space of improving the literacy of consumers and also the workforce education and training. But again, we stuck into what are the best models of integrated care, which it seems like things were not integrated for consumers. So this is the model that we came up with, the public health model to palliative care and end-of-life care, whereby we have the services on one side that needs integrating, and on the other side are the enablers. And as you can see, compassionate communities is a strong enabler in that field, whereby they're able to help integrate those services across those circles of care. So that's sort of one model that we're proposing how things can be integrated. Bruce.
Okay, so in a sense, to try to sum this up a bit, we've tried to make a distinction between what happens by simply the distinction between helping acts to put them into a framework where people begin to develop skills or capacity, but also to embed all that in a program for social change. And next slide shows the model or the framework which is basically underlying this program and probably helps to provide some points of comparison with other similar programs. And that is the argument, the new essentials argument, is that a comprehensive and effective end-of-life care system has at least these 4 subsystems involved in it. That is of specialist palliative care, primary care, informal care networks, and civic institutions. They're labeled slightly differently there, but that's essentially what they boil down to. And each of those systems or subsystems needs to be nurtured and encouraged and resourced to make its optimum contribution to end-of-life care. But they also need to be able to articulate and to complement and to reinforce each other. So part of the model, a good public health model, involves developing strategies which will engage different subsystems in collaborative and constructive sorts of ways. So with the Southwest program we've been talking about is a community-sponsored network that links local government, the civic institution, and regional health services, largely primary care services, to support the compassionate connectors who in turn support and enhance the informal social networks of the people and families who've been referred into the program by health services, although they could equally be referred in by community sources as well. Other programs will connect these various sectors or gear wheels or whatever you want to call them in ways which are appropriate to their context. Froome, for example, uses an enhanced primary care model that actually embeds community development workers within their primary care hub and programs. And then these health connectors develop literacy in the community through community connector training and support a variety of emerging community initiatives. The Canadian NavCare program is NavCare connectors or volunteers seem to be very much like our compassionate connectors here, although the role of the NavCare connectors seems to explicitly include both the connecting and helping functions. Our compassionate connectors are supposed to be mainly connectors, but given that many of the people referred into the program were quite socially isolated, as some has noted, the helping aspect also developed within the connector role. As far as I can see too from the literature, and maybe people will comment about this, the ownership of the NavCare programs can vary all the way from being an expansion of an existing volunteer program to developing a community outreach arm of a civic program. And so with that sort of thinking in the background, what are some of the issues that are involved in maintaining social or sustaining social change? Some of the lessons, I guess, if you like, which are reminders to us of what we need to do to maintain this as a public health program, is, first of all, ensuring that we pay attention to each setting is able to connect the informal care networks, community care programs, primary care, specialist palliative care in collaborative and not controlling ways. For us, we have an issue in ensuring that our connectors are supported to be network enhancers and to resist being simply recruited into helper roles. We also need, through the community stance of the Southwest Network, to remind health services that they are partners in the programs, not owners of the program. Health does not drive the program, they are participants and partners. And in that sense, understanding that the dots in the model, which was up a few slides ago, are connected by policies and collaborative partnerships, not through some sort of centralized bureaucratic structure. Each of those sectors needs to have reasonable autonomy to develop its own contribution and then enhance that contribution through constructive collaboration within that setting. And so it remains simply to say thank you for paying attention, those of you who have survived, and also to acknowledge particularly our sponsors, funders and supporters in kind, the range of both institutions and programs that are listed here. And some has already noted, particularly the support of the West Australian Department of Health and WA Country Health, but also our institutions have backed us up, and the community has bought in all sorts of ways through the Southwest Compassionate Communities Network. So thank you.
All right, guys, so we're going to move on to the Q&A portion, and I see that we have quite a few questions in the chat or in the Q&A section. So basically what we're going to do is I'm just going to sort of read them out, and our presenters hopefully will be able to answer the questions. So the first one we have is, how were you able to recruit those with chronic illness? Was it through referral or hospital or other services?
Yeah, so I'll probably answer that one. Yeah, so the chronic disease team, they get obviously patients referred to them, and then they make the decision which ones would be appropriate to the connector program. So it's all done within the health service. Yeah.
Great. Do those referred to the program ever become connectors themselves?
They say they would like to, like you've seen one lady in that movie. She did say that once she gets her life sorted after the death of her husband, she'd like to become a connector. Yeah, definitely. It's a bit like, you know, the hospice volunteers. You have so many families who go back and volunteer in hospices. So we do have that too. Yeah.
So it's just really maybe more of a case at this time. There hasn't been a long enough window for the program, right? Perfect.
Exactly. Yeah.
Yep.
So if volunteers did not appreciate the degree of their impact, would this impact volunteer recruitment? So if they're not, I think sort of they're not valuing the impact that they're making, would they fizzle away?
But the ones who are in the program have actually learned that how important their impact is, and we have managed in all our presentations to community forums to show that slide and say, look how much the patients are valuing your work. So please come forward and, you know, volunteer whenever your life, you know, allows that, basically. So, you know, we have managed to basically make sure the community understood that the impact was great, more than the volunteers themselves were able to articulate this at the time.
Yes, I don't think it's a matter of the volunteers not feeling that they were doing valuable work, but not appreciating the full impact of that work. Yeah.
Okay, another question is this program being licensed in any way in other parts of Australia? So I know you've talked about quickly expanding the program, but then also in other countries. So what's the potential expansion?
Yeah, I mean, we haven't reached that stage yet because we just finished the evaluation, basically. and the interest in other similar, sort of country areas. We're looking, I mean, there's a lot of discussions happening, how we roll it out and what needs to happen. So as such, we haven't reached that stage, but it'd be nice to reach that stage. And I think we let everybody know once it's licensed.
Yeah.
Great.
But I don't think we see this as a program which is simply transferable. It's a way of operating which needs to be understood and implemented appropriately in each setting, because each setting has to think it through for themselves, not simply borrow a series of strategies and hope that it might work.
Absolutely, that makes sense.
Yeah.
Another question. So it appears that mainly women are involved. Is this an issue with male participants? And I was thinking the exact same thing myself.
But I mean, isn't it the same in everywhere in the world? We've got more women who are doing this nurturing role. So we are trying, to attract more male patients by using more male, not patients. Are you talking, Jeff, about the male connectors, right? Yeah. So it's an issue with a male volunteering for this. And interesting, the couple that we have involved now, so moving on from that research trial, are in pastoral care, and they do that kind of work anyway themselves. So whether men have to come from a special kind of discipline to want to do that kind of connector work, I don't know. Bruce, you tell me, you've been in this space.
Well, look, I don't know. And I suppose if you look at registered carers in Australia, 2/3 are women, 1/3 are men. And I guess, again, that sort of is a burden of disease type of function in some respects. But yes, I mean, I guess even us old blokes are becoming a bit more sensitive, a bit more engaged. And I suppose one of the beauties of the connector role is that it has a nice variety of roles attached to it. And in that sense, I think it can cater to a broader range of personalities and interests, and hopefully more and more men will find a place within it.
Yeah, perfect. And certainly with the HIV problem, there were a lot of men who were carers, and they really were supporting their partners. So it's not like they don't have it in them, they can do it. It's just working on that, work in progress.
Great, thank you. Another question is, how are you organized and funded to deliver the program?
So far, the research trial was funded, for basically just a research component. The coordinator, which paid for the coordinator of connectors at the time, now that it's being translated into practice, the health service is looking after the salary of the coordinator of connectors. Beyond that, we don't have anything. Therefore, my mission this year is to knock at the door of our state health department and also federal health department to start looking at a national campaign first, because we've realized through this program, if we don't have the community well prepared to take up a role like this one, it's going to take a long time to actually roll it out anywhere else. So, I mean, I don't know, probably a few of you knew that I got, I was honored to be awarded the West Australian of the Year for this year. So I guess I'm going to use this platform basically to get a not only just a statewide campaign, but maybe a national campaign, so that we get the community really well prepared, that they have a role to play, they can do it. It is their responsibility in that space. So let's get them skilled again, give them the confidence again to be able to work alongside health services so that palliative care is accessible to everyone everywhere. So.
Great.
And there's a fairly unsubtle argument as well. Put 100K into employing a coordinator and we'll save $500,000.
Yeah, the business case for it.
I need to use that as well. Yeah.
Excellent. So we have a couple more questions, just so we can leave a few minutes at the end. So what is the connection with services provided by the MND Association of WA? I assume you guys will know what that means.
That's motor neuron disease, ALS.
Okay.
Yes.
Of course,
Yeah.
Jeff and I, we work in this space, and we have, so the interest is there to actually roll out the program to specific organizations or specific diseases. So that's again work in progress, but definitely people with motor neuron disease where, you know, until now, unfortunately, there's no cure or treatment for them, and they spend most of the time at home with their they will benefit a lot from having to be less socially isolated, them and their carers, and have the community around them rallying to help them. Yeah.
An MND association is a good example of a civic institution, which obviously has good links with the healthcare system, but nevertheless is actually a community organised and supported group. Yeah.
Great. Another question, can you speak more to your intention to engage with primary care? Is this about awareness of the program, referrals?
Yes, correct. All of the above. So once we have a bit of time and funding, that's the other thing, is how do we create awareness within general practitioners to create that integrated care, seamless care between what they are providing and also what can be provided by the connectors at the community level and the health services. I mean, obviously what I've heard from the GPs is that they have, you know, a lot of socially isolated people who keep coming, not necessarily for physical problems. And had they have a connector basically who's able to show them who they can be connected with and be part of all, you know, these community organizations that's available for them, that would be something that the GPs would be very interested in. But we got up everything, you know, to be able to get this going, and therefore the GPs can start referring to the program as well.
Next Tuesday night, the Australian budget comes down, and within it, we understand there is going to be discussion, at least, of new or expanded or different ways of organising primary care. So clearly, that's something important for us to be aware of. And it's always possible that something more like the MENDIP or the Froome model is something which could be contemplated in terms of this revision of primary care.
I was just going to say that about the Froome model. That's what it reminds me of. Yeah. Awesome.
Yeah.
Okay, another question we have here from Mary Lou Kelly. So she wanted to know about the program, if it could be used and adapted for local situations. And I think you've sort of mentioned that it can. And then basically, you know, she's attached to Compassionate Ottawa here in Canada, and just wondering, you know, could they connect with you guys on that? Because Compassionate Ottawa is engaging with 20 cultural communities right now. So maybe what your thoughts are on that.
That would be fantastic, Mary Lou. Thank you for suggesting that. That's amazing. I think, I mean, now that we finished from, you know, all that being absorbed by the research outcomes and we've got the evidence, you know, we're open to basically working with everyone who's interested in this model. And as Bruce said, if that model works for your communities, that would be fantastic.
Yep, terrific.
I just have one or two questions that I was sort of thinking about as you guys were presenting, and then I think we'll look at wrapping it up. One is, how much management time do you think is involved to manage the connectors and the helpers, sort of to get the sense of what would be required? Like, is this a full-time job for that person who's managing?
So it depends on the number of connectors. At the moment, we probably would have 10 who are active, because they come in and out of the program as their life circumstances allows. For now, we've got 2 days a week of a coordinator of connectors who, I mean, as a Compassionate Community Network, we are still helping the coordinator of connectors and the health service in terms of training, in terms of, you know, vetting the newcomers. So that would be the main cost, Bonnie, in terms of where the management need to go. Now, once the connectors are on board, they kind of manage the caring helpers. because the caring helpers are not connected to the health service. There are people who would provide help in an organic way in the community anyway, you know, the neighbor who would mow the lawn and stuff like this. So it's up to the connector to make sure that the caring helper is a good fit for the family and basically oversee that the family is happy with the help offering helper. Now, we've had a lot of instances where the families and the caring helpers have become really good friends. So the management is in layers kind of thing.
Yeah. That makes sense.
Yep.
Just one more question on my end, and I see we have a couple more that have come up. One is, has there been time for sort of debriefing for those community connectors? So early on in my career in this space, I had learned about the program in Scotland where they had volunteers in the library system. And one of the things that they learned very early on was that they needed to actually have debrief sessions with the volunteers. So is that something that exists in your program?
Yes, we've for the last 3 years, we've met with them regularly every two weeks by Zoom when we couldn't really do it face to face with the COVID thing. And to be honest, like as a research team who met with them, and we had a support system on board, like a grief counselor, because of course some of their families died. We learned from them a lot, and I think that Zoom meeting was important for them to connect together and learn from each other. What is it they're doing with those families that the other one can adapt or try that way of doing things? So it was more, they didn't need support as such, but we wanted to just know what they're doing, because that's the only way we are able to follow basically the important they're doing. Because as Bruce mentioned in one of the slides, they were so not autonomous and they had a lot of agency, and this is what they liked about their work. They didn't need to come back to us and take permission in any way. And we certainly haven't asked for this. But it was really interesting for us to see how they're operating and how resourceful they are. And they learned from each other. And although they were doing this by themselves before the program, what they said is that they liked being part of the program because it's like being part of a collegial group, a community of care, whereby they're able to exchange ideas and feel supported. So that's how it worked.
Great.
Yeah. So it's a reflective practice model or community of practice model, in effect. Yeah.
Okay, so we have two more questions and then we will have to move on to the last couple slides. So another question is, does this work in city communities?
Yes, we're going to see that. That's the next challenge, Jeff. I was told a lot here, you're operating in a regional rural area where people probably, they're more connected or more friendly, or, we hear that all the time. So, yeah, just watch that space. Jeff, we'll see how it's going to work. Now, whether we involve local government more there, to be able to do that work for us. I certainly presented yesterday to one of the largest sort of suburbs in Perth, where the deputy mayor, was there, and she was very interested in the program and asked me, how do we work with the health service to get this established? So again, that would be interesting, and I'm certainly looking forward to, seeing how it's going to work in the city.
Awesome.
Yeah. I mean, those basically those four subsystems or domains, or whatever to call them, are there. They're more complex in some ways within a city context, and some of the interactions are going to be require more negotiation. But the principles, I think, still apply.
Yep.
Okay, so we have another question. So how were the volunteers recruited? What supports were provided to them, and how much time commitment was asked of them to contribute?
So we put out an expression of interest on our website or social media, or the list that people have, that when we do like the Death Festival or Dying to Know Days, people leave their names that they want more information when the Southwest Compassion Community Networks do any of these activities. So basically we just mail or email all of them. We've got a next training program on such a date. Are you interested? Please, there's like a page where they feel why they're interested, what kind of volunteering experience they've had. We make sure we know if they've had a recent bereavement experience, because maybe they need to have a bit of space before they get into this for them. So that's the way. Now, the first lot that were part of the research trial, the research team had face-to-face interviews or by Zoom for all of them. But then we found out that really it doesn't matter, as long as they've got a good expression of interest, and we've reviewed this. It's almost they select themselves out after the training if they feel it's not for them. So we didn't need to worry if they were 100% suitable or not. They make that decision. And certainly this is what happened. So we may train 20, but only 10 decide that they want to stay part of the program. The time commitment is as little or as much as they want to provide. So again, there's no set time. But of course, once they've committed to a family and say they've decided to go overseas for an extended period of time, then maybe another connector would sort of follow up with their family so that they don't feel abandoned.
Fair enough.
Yeah, so the coordinator makes that judgment, I guess, doesn't she, something about that in terms of matching? Yeah.
Yes, they match. So, for instance, it's really important. The coordinator's role is so vital because he or she needs to know the connectors really well, their interests, their liking, and then, of course, know the families, what their needs are. And the matching has worked really well. So if we have a connector who's into the arts sector, and then, a family is really interested in that kind of thing, the rapport is really very quickly done between those. Yeah.
Great. Well, thank you for the questions, everybody. We need to move on just to the last couple of slides. I did see a question came up about getting access to the email. So they are in the chat there, as well as we can put them in that follow-up email so you guys can make the connections.
Yep, good.
Great. Okay, next slide, please. So just a couple of things from Public Health Palliative Care. So we have our next conference coming up. It's going to be in Bern, Switzerland. You can see the date there. So it's October 2024 in Bern, Switzerland. So hope to see some of you guys there. Next slide, please. And just the last piece is our intention is to have a second follow-up webinar sometime in June that pulls a couple of examples of this program around the world. So we can sort of look at different approaches taken. So NavCare is absolutely one of the ones that I'm hoping to recruit and reach out about the Frome model. But I'd also like to just say, if some of you know of a program that I haven't mentioned, I would love it if you could email me so that I can connect in with them and see about having them participate in this in the next webinar, because it's sort of very clear there are a variety of approaches here. And I think there's even an approach that's being taken sort of at the national level. So yeah, we're hoping to highlight some more examples in the next webinars. So hope to see you there. And if you have an idea, please pop me an email. So that's it. Thank you very much for joining us, everybody, from around the world. We had quite a few people from different places. And thanks to those who are up early, which include the ECHO staff here in Ontario. We do have a feedback survey, so if you could fill that out for this session, that would be great. I believe it's just been dropped into the chat. And then thank you to our presenters very much, guys. I loved the research, and so certainly it was great to hear so much more about the program and the impact. So thank you for taking the time to share your great work with us. And that's it. Everybody have a wonderful day.
Thank you, the ECHO group, fantastic work. And yeah, we're very pleased that we had this opportunity. So wonderful.
All right, everybody have a wonderful day.
Yeah, well, we're gonna go and sleep now, and you're gonna have a good day.
Yes. Bye, guys.
All right, bye-bye.